Hello, good evening, everyone. It's 6 p.m. Saturday, June 4th in Orlando, Florida. And on behalf of the Orlando Health Digestive Health Institute, I would like to welcome you to the Digestive Diseases 2022 highlights. We are going to present a summary of abstracts that were presented in SanDiego 2 weeks back. So we are gathered here in Orlando with some of our referring doctors who are our very good friends and our colleagues. And for those of you joining us worldwide online, wherever you are, I would like to welcome you to this DDW 2022 highlight. We have selected the abstracts based on clinical relevance, the design of the clinical trial. We give preference to randomized trials, and we're going to be presenting 50 top abstracts. The abstracts have been categorized into 4 sections. One is going to be advanced endoscopy, followed by liver, and then general gastroenterology, and finally inflammatory bowel disease. We have a very special guest to moderate. Dr. Girish Mishra is a professor of medicine and division director of gastroenterology and hepatology at Wake Forest University School of Medicine. We have known Dr. Mishra for 20 years. He is not only a division chief, but an excellent academician. So he'll be moderating this session. And I'm going to invite my colleague, Dr. Jiang Bang, who's an interventional endoscopist and director of clinical research at the Digestive Health Institute, to give her presentations on advanced endoscopy.
All right, thank you so much, Dr. Varadarajilu. So we're going to kick off the session with endoscopy and pancreatibiliary abstracts from DDW this year. Okay, so our first abstract is by Vosu et al. It's titled The Trainee Involvement in ERCP Risk Score Study. The aim of the study was to predict adverse events in ERCPs with trainee involvement. So the methods is that it was a prospective observational study evaluating the accuracy of proposed risk score in predicting procedure-related complications. They looked at data on consecutive ERCP procedures with hands-on trainee involvement. Patients were followed for 30 days to assess the outcomes and adverse events. They gave different scores according to the risks involved: 1 point for bilirubin greater than 10 or native papilla, 2 points for grade 2 or more complexity, and 3 points for failed ERCPs in the past. The primary outcome measure was to look at the technical failure or any procedure-related adverse events which prolonged hospital stay. So they looked at 1,283 ERCP procedures by 11 supervisors and 10 trainees from 5 European centers. 409 ERCP procedures had trainee involvement, while the rest served as control. 37.9% of the patients were classified as high risk. They then compared their technical success and adverse events according to the risk involved. So they found that technical success was significantly higher for the low risk group at 93.1% versus 79% for the high risk group. And for adverse events, they found that the rates were much lower with a low risk group at 17% versus 27% for the high risk group, with p-value of 0.022. On multivariable regression analysis, the risk score was the only significant predictor of adverse events with an odds ratio of 1.38 for each additional point on the risk score scale. So the trainee involvement ERCP risk score model performed fairly well in real life setting and has the potential to personalize ERCP training by allowing novice endoscopists to start their hands-on training in selected low-risk cases, thus increasing patient safety. Our next study is by Nabiki et al. From Japan, and it's titled Prevention of Post-ERCP Pancreatitis After Endoscopic Stenting. This is a multi-center prospective cohort study. They looked at the incidence of post-ERCP pancreatitis after endoscopic biliary stenting for malignant biliary obstruction with and without endoscopic sphincterotomy in a multi-center prospective cohort study. In 598 patients, plastic stents were inserted, and 209 patients had metal stents placed. The endoscopic sphincterotomy was performed in 486 patients. So when they looked at the incidence of post-ERCP pancreatitis in patients with sphincterotomy, the rate was 8.2% versus 6.9% in those without endoscopic sphincterotomy. And this p-value was not significant at 0.5. When they looked at pancreatitis rate in patients who had metal stents, the rate was 9.2% in those with sphincterotomy versus 5.4% in those without. Again, this difference was not statistically significant. When they looked at patients with plastic stents, with stents across the papilla, the rate of pancreatitis was 8.2% in the sphincterotomy group versus 7% in those without sphincterotomy. And again, this difference was not statistically significant. So in conclusion, endoscopic sphincterotomy does not contribute to prevention of post-ERCP pancreatitis after biliary stenting for malignant biliary obstruction, even in cases of insertion of fully covered metal stents placed across the major papilla. Our next study is by Desai et al., entitled The Impact of Withdrawal Time on Adenoma Detection Rate. So what they did was the aim was to look at the impact of withdrawal time on adenoma detection rate, or ADR, and determine the threshold for withdrawal time beyond which the ADR does not increase. So these authors looked at the withdrawal time of subjects undergoing screening and or surveillance colonoscopy in a prospective randomized trial. The relationship of withdrawal time in 1 minute increments on the ADR was reported as odds ratios and confidence intervals. They looked at data on 1,142 subjects who underwent screening or surveillance colonoscopy. And the screening group had median inspection time of 9 minutes with ADR of 49%, while for the surveillance group, it was 9 minutes with ADR of 64%. ADR continued to increase significantly for increase in inspection time from 6 minutes to 11 minutes at 50% versus 65%. And for every 1 minute increase in inspection time, there was a 6% increase in adenoma detection with odds ratio of 1.1. Upward trend in adenoma detection rate probability was seen until withdrawal time of approximately 13 minutes, beyond which the ADR did not increase further. So in conclusion, an incremental increase in ADR of 6% increased with every additional minute, with a withdrawal time of up to 13 minutes was seen in the study, beyond which ADR did not increase. Next is a study by Capogreco from Italy looking at cold versus hot EMR for large duodenal adenomas. The aim of this study was to assess the performance cold and hot EMR in the duodenum. So these authors looked at patients who underwent cold EMR for duodenal adenomas at least 2 centimeters in size between 2019 and 2021 at 4 European centers. All patients then underwent endoscopic follow-up at 3 to 6 months from index procedure. As a control group, they looked at patients undergoing hot EMR, and they analyzed the data retrospectively. So in this study, they had 31 patients who underwent cold EMR and 101 patients who underwent hot EMR, with mean lesion size of 31.1 millimeters and 37.7 millimeters respectively. There was no significant difference in technical success between cold and hot EMRs at 93.5 versus 89.1%. However, the procedural time was significantly lower for cold EMR at 48 minutes versus 96 minutes. And while there was no adverse event seen in the cold EMR group, the hot EMR group had adverse events that were visualized, that occurred with 17 intra-procedural adverse events and 27 post-procedural adverse events. That included 4 perforations and 13 instances of severe bleeding. After procedure, 17 patients had bleeding that required reinterventions. They had 2 delayed perforations, of which 1 resulted in death. They had 3 cases of fever and 4 other types of adverse events. The recurrence rate was not different between the cold and hot EMR groups. So in conclusion, cold duodenal EMR appears to be faster and, above all, much safer than hot EMR. Okay, our next study is by Saito et al., and this is looking at long-term outcomes after ESD for colorectal neoplasms. The aim of this study was to clarify the long-term outcomes of ESD through a large-scale multi-center prospective study. They looked at 1,883 patients enrolled over a period of 2 years, and ESD was performed in 1,965 lesions. or the lesions were at least 2 centimeters in size. The primary outcome measure was a 5-year survival rate and intestinal preservation rate. They also looked at disease-specific survival and overall survival and compared it between patients who underwent complete resection of the lesion versus non-complete resection of the lesion. So they found 1,814 lesions in 1,740 patients. Average tumor size was 32 millimeters, and 97% of the lesions were removed en bloc by ESD, and 1,640 lesions were finally diagnosed as being pathologically curative. The proportion of disease-specific survival rate was 100%, 99.9%, and 99.6%, and the overall survival rates were 99.6%, 97.4%, and 93.6% at 1, 3, and 5 years after initial treatment, respectively. The Kaplan-Meier curve for survival revealed that disease-specific survival rate was higher in patients with complete resection compared to those without. And the same tendency was also confirmed with the overall survival rate. The 5-year intestinal preservation rate was 89%, which is substantially higher in patients with completely resected lesions. Of 1,503 lesions in 1,437 patients at 5-year follow-up, local recurrence occurred only in 0.5% of lesions that were managed endoscopically. So in conclusion, this study shows that long-term outcomes after ESD for treatment of colorectal neoplasms at least 2 centimeters in size is favorable, with 5-year disease-specific survival and overall survival rates that were 99.6% and 93.5% respectively. These results suggest that ESD can be a potential first-line therapy for superficial colorectal neoplasms at least 2 centimeters in size. Our next study is by Jacques et al. From France, is comparing ESD and piecemeal EMR for large laterally spreading lesions, and it was a randomized controlled trial from France. The aim of this randomized controlled trial was to compare ESD and piecemeal EMR in patients with large laterally spreading colon polyps. This was a multi-center, single-blinded randomized trial involving 6 centers and 11 endoscopists comparing ESD and piecemeal EMR with snare tip thermal ablation of the margin for large, low-risk, laterally spreading lesions in the colon. The primary outcome measure was recurrence at 6 months. 359 patients were randomized, 177 to ESD and 182 to piecemeal EMR. 70% of the patients had granular lateral spreading lesions with mean size of 42.9 millimeters. 60.3% of the lesions were in the right colon, with complex lesions seen in 80% of the cases. They found that there was a significant difference in recurrence rate at 6-month follow-up in favor of ESD, with recurrence rate of 0.6% in ESD versus 5.1% in EMR. The RO resection rate was higher for ESD at 93.8% versus 12.1% in the EMR group, with p-value of less than 0.001. They also found that there was no difference in treatment failure, perforation, surgical complications, delayed bleeding, deep or superficial mucosal cancers between the 2 groups. So in conclusion, ESD is superior to piecemeal EMR on 6 months follow-up regarding recurrence rates without increasing the morbidity. This is our next study is the study from China by Liu et al., looking at a novel method of performing POEM called the Lu POEM versus conventional POEM for treatment of achalasia. To further improve traditional POEM and simplify the procedure, a novel approach called Lu POEM that combines submucosal tunneling with myotomy was introduced. And the study basically compared the technical feasibility, safety, clinical efficacy of the 2 different techniques for POEM in treating patients with achalasia. So this was a multi-center randomized trial with consecutive patients undergoing POEM for achalasia. The primary outcome measures were success rate, with secondary outcome measures of procedural time, duration of hospital stay, symptom remission rate according to the Eckhart score, complication rates, and recurrence at 6 months. 100 patients were enrolled and were randomized to either the Lu POEM or traditional POEM Technical success was 100% for each group. The average procedure time for the LU-PERIM was significantly shorter than for traditional PERIM at 15.1 minutes versus 32.5 minutes. 32.5 minutes versus 51.1 minutes, with p-value of less than 0.001. There was no significant difference in hospital stay or Ercp score at 3 and 6 month follow-up between the two groups. So in conclusion, LU-PERIM and traditional PERIM provided similar outcomes in the treatment of achalasia in terms of efficacy and recurrence. However, the advantage of LU-PERIM is that it results in significantly shorter procedural time and the fact that the procedure is made more simple. Our next study is by Sung et al. In a study from Hong Kong, looking at artificial intelligence-assisted colonoscopy for adenoma detection in screening colonoscopy. The aim of this study was to compare AI-assisted colonoscopy to standard colonoscopy for adenoma detection in screening population. They took asymptomatic patients undergoing colorectal cancer screening, and they were randomized to either AR or standard group. A convolutional neural network-based polyp detection system with real-time visual notice on the monitor was used during intubation and withdrawal in the AI group. The primary outcome measure was adenoma detection rate, and other outcome measures included mean number of adenomas per colonoscopy, adenoma detection rate according to the experience of the endoscopist, and withdrawal time. 3,059 subjects were randomized, 1,519 to AI and 1,540 to the standard group. The ADL was significantly higher for AI group at 41% versus 33.7%. In AI group, ADR of the senior endoscopist, overall ADR of junior endoscopists, adenoma detection rate, polyp detection rate, detection of advanced adenomas, detection of adenomas that were small, less than 5 millimeters, larger adenomas greater than 10 millimeters, detection of non-pedunculated adenomas, detection of proximal colon polyps and distal colon adenoma detection rates were all significantly higher. The median withdrawal time was slightly longer for the AI group. In conclusion, AI-assisted colonoscopies improved ADR in the proximal distal colon for detecting non-advanced adenomas, small polyps, and non-peduncular adenomas when performing screening colonoscopy. Our next study by Antonelli et al. Is from Italy, titled Artificial Intelligence for Leaving in situ Colorectal Polyps. The aim of this study was to evaluate performance of first AI system capable of predicting polyp histology during real-time colonoscopy using standard of care non-magnified white light images. They used a deep learning module called CADEX module for differentiating adenoma and non-adenomas in unmagnified white light colonoscopy. And they tried to validate this module. For each polyp, the CADEX output endoscopist diagnosis with advanced imaging was matched against gold standard histology. The negative predictive value for adenoma detection for adenomatous histology of polyps less than 5 millimeters in size in the rectosigmoid region by CADEX and AI-assisted endoscopist was calculated, as well as the agreement between CADEX and histology-based post-polypectomy surveillance intervals according to European and American guidelines. 544 polyps were removed in 162 patients, of which 54% were small polyps less than 5 millimeters in size located in the rectosigmoid colon. CADEX diagnosis was feasible in 98.6%, and negative predictive value for rectosigmoid polyps 5 millimeters or less in size was 97.6%. Based on the CADEX output, 39% of the polyps would be amenable to the resect and discard strategy, resulting in a 95.6% and 95.9% agreement between CADEX and histology-based surveillance intervals, according to the European and American guidelines. Therefore, in conclusion, the new CADEX system can predict polyp histology during colonoscopy using standard of care non-magnified white light images. Bypassing the need for advanced imaging, CADEX incorporates optical diagnosis in the same white light setting of detection, simplifying the diagnostic process of colonoscopy. Our next study is by Monachese et al. This is US-guided polysystemic pressure gradient evaluation predicts liver histology and clinical parameters of liver disease. The aim of this study was to evaluate correlation between EUS-guided portosystemic pressure gradient and clinical markers of portal hypertension, non-invasive markers of liver disease, and liver histology. This was a multi-center study of patients undergoing EUS-guided portosystemic pressure gradient measurement in patients with known or suspected liver disease. EUS portosystemic pressure gradients of more than 5 and more than 10 millimeters of mercury were compared against non-invasive markers and liver histology. Logistic models and linear regression analysis was performed. The US-guided portosystemic pressure gradient evaluation was technically feasible in 98.1% of 159 patients, and adverse events were seen in 1.2%, which comprised bleeding occurring post-liver biopsy. The mean portosystemic pressure gradient was 5.7, and 43% had a pressure gradient of more than 5. Higher mean portosystemic pressure gradients were measured in patients with clinical features of portal hypertension, including esophageal varices, portal hypertensive gastropathy, and thrombocytopenia. In patients with gradient with more than 5 or 6 times more likely to have advanced fibrosis on histology of stage 3 or 4 with odds ratio of 6. And the portosystemic pressure gradient measurements correlated well with stage 4 fibrosis, ASD to platelet ratio index, and MELD scores. In conclusion, EUS-guided portosystemic pressure gradient demonstrates strong correlation with clinical parameters of portal hypertension and histological evidence of advanced fibrosis. EUS-guided portosystemic pressure gradient may be a more sensitive indicator of advanced liver disease than current non-invasive tests. Our next study is by Albuis et al. From France, titled Short and Long-Term Efficiency of EUS-Guided Biliary Drainage Using Electrocorder-Enhanced Lumen-Producing Metal Stents in Cases of Failed ERCP. The aim of this study was to evaluate the efficacy and safety of lumen-producing metal stents, mostly 6 millimeters in diameter, for biliary drainage and to monitor long-term complications, including the development of stent dysfunction. This was an observational, prospective, single-center study, including all patients who underwent EUS-guided biliary drainage for distal malignant obstruction using 6 millimeter electrocorder-enhanced lumen-producing metal stents. The primary objective was to evaluate long-term rate of stent dysfunction. Secondary objectives were to identify risk factors and to identify risk factors for stent dysfunction. A total of 118 patients were included in this study and underwent EUS-guided biliary drainage procedures for distal malignant biliary obstruction. The technical success was 97.4% with clinical success of 95%. The rate of stent dysfunction during follow-up was 16%, with significantly increased risk on multivariate analysis when the patients had cholangiocarcinoma, presence of duodenal stent, and bile duct diameter of less than 14 millimeters. So in conclusion, the rate of stent dysfunction during follow-up in patients undergoing EUS-guided biliary drainage using lumen-producing metal stents was 16%. Bile duct diameter of less than 14 millimeters, presence of a duodenal stent, and presence of a distal cholangiocarcinoma constitute risk factors for stent dysfunction during follow-up. Our next study is by Velázquez Rodriguez et al. From Spain, and this study compared plastic and lumen-producing metal stents for patients undergoing EUS-guided drainage of walled-off necrosis. The conclusion of this study was that in 61 patients who underwent either pigtail or lumen-producing metal stent insertion for drainage of pancreatic fluid collections, there was no significant difference between the two groups except for the shorter procedural duration with LAMS, which confirms our prior randomized controlled trials. Next study by Sharma et al. Looks at safety and efficacy of EUS-guided benign liver biopsy using wet suction or slow suction or slow pull techniques. And in this study comprising of 153 patients, the histological outcomes were superior in the wet suction arm compared to the slow pull technique. When they looked at total fragment length, they were longer for the wet suction group. The length of longest fragments also longer for the wet suction group, and the number of portal tracts was also superior for the wet suction group. Our next study by Vanek et al. From the Czech Republic is titled Stent with or without coaxioplastic stents for treatment of pancreatic ward-off necrosis. And in this study, they found that the rate of adverse events was significantly lower when plastic stents were inserted within the lumen of the lumen-proven metal stents, with the adverse event rate of 20% versus 51.5% in those without coaxioplastic stents. Stent obstruction was the most frequently observed adverse event with a rate seen of 36.3% versus 14.7%, and there were no other differences observed. Our next study is by Zweger et al. This is titled Adverse Events of Endoscopic Full Thickness Resection. And the aim of this study was to determine the occurrence of adverse events in patients undergoing colorectal full thickness resection. This was an observational study of patients in the German and Dutch national colorectal full thickness resection device registries between 2015 and 2021. All early and late adverse events were analyzed. They looked at severe adverse events as well, and they defined that as those requiring surgical intervention. 1,894 patients underwent full thickness resection between the two databases, and the results were analyzed. Indications for full thickness resection were early carcinoma in 697 patients, difficult adenomas in 998 patients, subepithelial tumors in 107 patients, diagnostic purposes in 16, and other indications for 76 patients. The total adverse event rate was 11.1%. Perforations occurred in 2.5% of cases, and they included 27 direct intraprocedural perforations and 20 delayed perforations. Endoscopic closure was performed in 34% of cases, in 13 patients who had intraprocedural perforation and 1 delayed perforation, and conservative treatment with antibiotics was necessary in 4.3% of the cases. The rate of appendicitis for appendiceal lesions was 10%. Severe adverse events requiring surgery was 2.3%, and these concerned emergency surgeries for delayed perforation in 0.9% and direct perforations in 0.7%. Delayed perforation occurred between day 1 and 10 post full thickness resection, with median duration of hospitalization of, mean post full thickness resection, median time following index procedure of 2 days. There was no procedure-related mortality. In conclusion, colorectal full thickness resection is a relatively safe procedure with low overall risk of severe adverse events and no fatal incidents. Patients should be well informed on the risk of delayed perforation and the risk of secondary appendicitis following full thickness resection. Our final study for the endoscopy section is by Blackford et al. This is titled Surveillance of High-Risk Individuals Leading to Lower Stage Pancreatic Ductal Adenocarcinoma Diagnosis and Improved Overall and Disease-Specific Survival. The aim of this study was to compare overall survival and stage distribution of screen-detected pancreatic cancer with a control population of patients with pancreatic cancer in the United States. The methods is that they looked at screen-detected pancreatic cancer in high-risk individuals, and these patients are enrolled in the CAPS sites. It stands for Cancer of the Pancreas Screening Site from 1998 to 2020. And they compared this population to patients who had pancreatic cancer from the SEER Research Plus database. The mean tumor size in the 23 CAPS patients was smaller than the 230 SEER control patients. There was a significant shift to lower stage pancreatic cancer in the CAPS patients, with a greater proportion of stage 1 and stage 2 screen-detected pancreatic cancer patients compared to controls. 21.7% of CAPS pancreatic cancer were metastatic, compared to 50% in the control pancreatic cancer patients. CAPS patients had a median overall survival of 144 months, while the matched SEER pancreatic cancer cases had shorter median survival of only 37 months. In patients with non-metastatic pancreatic cancer, 1 year and 5 year overall survival was greater in CAPS patients versus control, with 1 year survival from 94% in CAPS versus only 76% in SEER, 5 year survival of 61% in CAPS patients versus 37% in SEER patients. The cumulative disease-specific mortality at 1 and 5 years was significantly lower, at 6% for CAPS versus 20% for CA patients, and 24% of CAPS at 5 years versus 58% for CA patients. Notably, 39% of CAPS pancreatic cancer patients survived more than 5 years. In conclusion, surveillance of high-risk individuals leads to detection of lower stage and smaller pancreatic cancers with associated decreased mortality and improved survival in a limited cohort of patients undergoing surveillance for pancreatic cancer. So this concludes the section on endoscopy. Dr. Mishra will also make some comments.
Good evening, everyone. Wow, that was quite a whirlwind. Great job. I just want to, before I sort of give my thoughts on the endoscopy section, just say thank you to Dr. Shyam Vardarjulu, Dr. Rob Hawes, Dr. G. Bang, Dr. Sunena, Dr. Ivnathan, and Dr. Morley for inviting me. This is an amazing event, and I think I congratulate all of you, the organizers. The entire group, and I know Shyam's kind of the driving, motivating, the persistent, the pit bull, if you will, driving all this, but it is going to be a special place, and it already is. And I can't wait to see in a year or two what the place physically looks like. Philosophically, it's almost there. So congratulations to everyone who has shared in this vision. Because I think it's going to be unlike any place in the world, and all of you are privileged to have it right here in Orlando. So just a couple thoughts. Again, my name is Gurish Mishra. I'm at Wake Forest University, and I'm one of Rob's boys, if you will. G, I thought it was a great summary. If I could just go back, I like to block things. And to sort of dissect down all of the abstracts at DDW, if you think of a couple of big segments, one would be quality, the other would be sort of complications or adverse events, third would be training, fourth would be AI. The fifth, I think, is, now you're showing that poems is here, but we're actually dissecting poems literally to different types of poems. So I think that's pretty neat. The whole field of endo hepatology is within us. And then finally, sort of the other big group is EUS-guided drainage for failed ERCP. So those are the sort of the big overall pictures or subheadings. And I'm not going to go through everything that she said, but just to take a step back and offer perspective in terms of quality. I think it's really neat, the study with the ADR and withdrawal rates. And I'm going to take this back to our trainees and to my colleagues. But I think it was a very well done study with a large number of patients, prospective. But if you can increase your ADR by 6% with each minute up until 13 minutes, I think that's a pretty powerful message for trainees. One of the things that I think all of us are facing is we're expanding. So part of my role is we have an expanding network of hospitals, and there are folks that practice endoscopy and colonoscopy different than I was trained. And so when I get to these rooms and then the nurse or tech turns on the clock watch or the stopwatch for 6 minutes, to me, it's like, that's rubbish. I don't need a clock to tell me how to practice. I will never finish a withdrawal in 1 minute, but if it happens to be 5 minutes and I got a great look, then so be it. But I'm never going to get done probably in 6 minutes if I do a good quality exam. And so this is the kind of data that's going to be really important, that we are not just technicians. We have to put everything in context. So I thought that was really a neat study. Ji, you mentioned already the complications and adverse events between the stents and doing a sphincterotomy or not, and that made no difference. I thought that was pretty neat. Cold snare versus hot polypectomy for large duodenal adenomas. I think there's a growing shift to doing cold snare polypectomy in large polyps. But this study for large duodenal adenomas not only showed that the cold was quicker, but had much less adverse events. I thought that was pretty neat. One of the studies, I'm pretty sure you highlighted this, maybe Shyam took this out when he truncated your slides, but you reviewed EUS guided gallbladder drainage versus percutaneous gallbladder drainage in patients that were unwell, to see if they later could undergo surgery and to see what the outcomes were with acute cholecystitis, and there was no difference. So I think we're seeing now prospectively in good randomized studies that EUS guided interventions does not make it an untoward event to later doing the definitive therapy. So I thought that was pretty neat. Training you covered, if you can, we all know that training in ERCP could pose patients at high risk. So if you can identify two different groups, high risk group versus a low risk group, and perhaps on the high risk group, not let your trainees spend as much time in those patients because of the high risk, I thought that would be very useful. I think the whole notion of AI is going to be, it's here already. For the group and the audience, just there's, I'm not going to go through the physics of it, but so you have AI built in the scope or in a separate box, if you will. So I think there's going to be a shift there in what type of AI is available to your center or to your endo unit. And just a couple of summary points with that. I think you've shown by the studies that you reviewed, that there's improved detection. There's also AI to see if you adequately resected that polyp. So that's another application. I thought the cost-effective study was really neat because with AI, in addition to screening colonoscopy, the AI decreased the colorectal cancer risk from 44% to 49% and mortality from 45% to 52%. So we know that colonoscopy saves lives by detecting colorectal cancer. But these types of studies, so they predicted with this modeling that with AI, you can diagnose 9,000 colorectal cancers per year more and save 2,600 deaths for a saving of $290 million, which I thought was pretty remarkable. Just know that not all poems are created equally. So you have poems that you can tie with fundoplication, poems that are built with anti-reflux capabilities, and then the Lu poems. Again, I don't do poems, but just taking a step back, just knowing that there are different types of poems when you review the literature and the studies. Finally, just to complete, there's Endo Hepatology. And then one of the things that she had reviewed, I was actually very fortunate as the chair of the EUS programming committee for ASGE. So our session actually had all the oral presentations, and the one with the CAPS database comparing to SEER database. So Mimi Canto is one of the senior authors. And the question, so the whole notion here is EUS for screening for high-risk individuals with pancreatic cancer. All of us are seeing much higher risk. So the BRCA1 mutations, BRCA2, Lynch syndrome, Pitt-Jaegers, the family history. It's in our practice for folks that do EUS. And so the discussion was, is this a lead time bias, or is it really that EUS in high-risk individuals is picking lesions up earlier and saving, mortality? And the data supports that it's not a lead time bias, but probably shift staging. So it's real. So those are my thoughts there in terms of reviewing the endoscopy portion to gain some perspective. I'm going to turn it over to the medical director at Digestive Health, Dr. Arvind Murli.
Perfect. So without further ado, we'll move on to our liver research abstracts or presentations at DDW. So the first presentation is on hepatorenal syndrome, acute kidney injury, formerly called as HRS type 1. So it is a rapidly progressing, often fatal condition, with the only curative treatment being liver transplantation. In this study, the authors looked at terlipressin, a splanchnic vasoconstrictor that is used in many other parts of the world, but not yet approved in the United States. So they looked at terlipressin in combination with albumin to see if it helps improve renal function and decrease the need for renal replacement therapy, specifically in patients aged greater than or equal to 65 years with acute kidney injury from hepatorenal syndrome. CONFIRM is the largest randomized controlled study to date in patients with HRS-AKI. In this study, patients were randomized to either receive terlipressin plus albumin or placebo plus albumin for up to 14 days. The primary endpoint was verified reversal of HRS-AKI, which was defined as 2 consecutive serum creatinine measurements of less than or equal to 1.5 milligram per dl, at least 2 hours apart, and survival without renal replacement therapy for at least 10 days after the end of treatment. Specifically in this presentation, they looked at a subgroup analysis of patients greater than or equal to 65 years. They had 300 patients in the CONFIRM trial. 53 were aged greater than or equal to 65 years. 35 were randomized to terlipressin and 18 received placebo. Mean MELD scores were similar in both groups. The authors showed that receiving terlipressin was associated or was 3 times more likely to achieve the primary endpoint as compared to placebo. Notably, about 31.4% versus 16.7% patients in the terlipressin and placebo groups, respectively, experienced durable HRS-AKI reversal, which was defined as a reversal of hepatorenal syndrome without needing renal replacement therapy up to day 30. Patients treated with terlipressin also had a shorter mean hospital stay, and they had a decreased need for renal replacement therapy. By day 90, the incidence of renal replacement therapy among survivors was about 29.4% for terlipressin and 66.7% for placebo. More importantly, among the 53 patients, 14 patients received transplant, of which 8 patients were from the terlipressin group and 6 patients from the placebo group. None of the 8 patients in the terlipressin group required renal replacement therapy after transplant, whereas 5 of the 6 patients in the placebo group required renal replacement therapy following transplant, and this was statistically significant. So the authors concluded that terlipressin, by causing splanchnic vasoconstriction, improving renal perfusion, and reversing or restoring renal function, it improves post-transplant outcomes in the highly vulnerable patient population aged greater than or equal to 65 years. The next study, we move on to non-alcoholic fatty liver disease. As everyone knows, non-alcoholic fatty liver disease incidence is increasing globally. Bariatric surgery is an important treatment option for patients with fatty liver disease and obesity. This can be done either via restrictive procedures, sleeve gastrectomy, or foregut bypass procedures, the Roux-en-Y gastric bypass. In this meta-analysis, the authors compared foregut bypass procedures versus restrictive bariatric procedures in patients with non-alcoholic fatty liver disease. Their primary endpoints was histological resolution of clinically significant fibrosis, resolution of steatosis, hepatocyte ballooning, and resolution of hepatocyte inflammation. The secondary endpoints included reduction in biochemical and metabolic parameters, including BMI, hemoglobin A1C, LDL, and HDL. They did a pairwise meta-analysis to compare the 2 procedures, and they obtained odds ratios and mean differences. They included 24 articles over 1,800 patients, of which about 52% received restrictive bariatric, 52% received foregut bypass surgeries, about 48% received restrictive bypass procedures. The foregut bypass procedures significantly reduced fibrosis. However, the restrictive procedures did not. Foregut bypass procedures significantly improved hepatic steatosis, lobular inflammation, and hepatocyte ballooning. For metabolic parameters, foregut bypass procedures again significantly lowered the BMI and the LDL compared to the restrictive procedures. Interestingly, they noted that restrictive procedures lowered the hemoglobin A1C more than the foregut bypass procedures. There is no change in ALT or AST between the two procedures. So the authors concluded that significant histological and metabolic advantages are associated with foregut bypass procedures as compared to restrictive bariatric procedures, and this should be considered in the management of patients with NAFLD. Staying on with our bariatric surgery. So about 8% to 15% of patients develop symptomatic gallstone disease within 24 months after bariatric surgery. So in this multi-center randomized placebo-controlled double-blind superiority trial, the authors aim to determine if prophylactic use of ursodeoxycholic acid for a period of 6 months after bariatric surgery decreases the incidence of symptomatic cholelithiasis after bariatric surgery. So the patients with an intact gallbladder and morbid obesity who were scheduled for either gastric bypass or sleeve gastrectomy were assessed for eligibility. They were randomly assigned to either ursodeoxycholic acid, 900 milligram daily for 6 months, or placebo. And the randomization was stratified for the presence of gallbladder stones, either at preoperative ultrasonography and for the type of surgery. Their primary endpoint was symptomatic cholelithiasis within 24 months. And they defined this as requiring hospital admission or a hospital visit for symptomatic gallstone disease. About 985 patients were randomly assigned to either ursodeoxycholic acid or placebo. A majority of these patients received Roux-en-Y gastric bypass. At baseline, asymptomatic gallstones was present in about 20% of patients. So 80% did not have any gallstones at the time of surgery. The primary endpoint occurred in 6.5% in the UDCA arm and 9.7% in the placebo arm, and this was not statistically significant. However, when adjusted for the presence of gallstones at baseline, treatment with UDCA was associated with a significant decrease in the incidence of symptomatic cholelithiasis after bariatric surgery. At primary endpoint occurred in 16 of 381 patients without asymptomatic gallstones at baseline, 4.1% in the UDCA arm, and 8.9% in the placebo arm. So the authors concluded that in patients undergoing bariatric surgery who did not have gallstones at baseline, prophylaxis with UDCA for 6 months after surgery reduces symptomatic cholelithiasis at 24 months after surgery. Okay. NASH is what everyone looks at these days. So we have another study on NASH, and this is on the effect of endoscopic gastric plication on liver fibrosis in patients with NASH. So fibrosis stage is the strongest predictor of mortality in patients with NASH. Weight loss of 7% and 10% is required for improvement in NASH and fibrosis, respectively. The aim of the study was to assess the efficacy of an emerging weight loss therapy, endoscopic gastric plication, for the treatment of NASH. It was a prospective registry study of patients who had endoscopic gastric plication, only patients with elevated hepatic fibrosis. So they included patients with F2 fibrosis, F3, and F4. Patients with cirrhosis and clinically significant portal hypertension, which they defined as a liver stiffness measurement greater than 25 kilopascals. These patients were placed on a non-selective beta blocker prior to the procedure. Patients with the decompensated cirrhosis were excluded. Endoscopic gastric plication device was used to place full thickness plications in the gastric body. The primary outcome was improvement in liver fibrosis as measured using elastography and other non-invasive markers, the NAFLD fibrosis score and the FIB4 index. The secondary outcomes were liver biochemistry, steatosis, hemoglobin A1C, insulin resistance, total weight loss, severe adverse events, and outcome predictors. They included 42 patients in the study. The mean age was 51. These patients all had NASH, 8 had F2, 16 had F3, 18 had F4 fibrosis. Only 4 patients had clinically significant portal hypertension per their criteria. The baseline BMI was close to 40. Their baseline CAP score and LSM were 335 and 13.8 respectively. Their technical success was 100%. The gastric body was shortened by a mean of 19 plus or minus 6 centimeters, which represented a reduction by 73%. The primary outcome, which is a liver stiffness measurement, decreased from 13.8 to 8.4. 67% of patients experienced greater than or equal to 1 fibrosis stage improvement. 94% exhibited no worsening of fibrosis. There were 4 patients with clinically significant portal hypertension, and all 4 patients did not have evidence of clinically significant portal hypertension after their procedure. Similarly, there was improvement in the NAFLD fibrosis score as well as the FIB4 index, and this was statistically significant. There were significant reductions in ALT, the CAP score, hemoglobin A1C, as well as the HOMA insulin resistance index following the procedure. At 6 and 12 months, patients experienced a percent total weight loss of 13.6 and 14.2 respectively. At 12 months, 94% of patients reached the 7% threshold. 63% of patients received the 10% total weight loss threshold. The serious adverse event rate was about 4.8%. 1 had gastric perforation and 1 had pulmonary embolism. So the authors concluded that endoscopic gastric plication appears safe and effective at treating NASH with significant reduction in liver fibrosis, even in patients with cirrhosis and portal hypertension. Alpha-1 antitrypsin PIMZ variant has been considered a disease modifier in patients with other chronic liver diseases. In this study, the authors looked at the effect of heterozygous alpha-1 antitrypsin PIMZ genotype in the risk of development of hepatic events in patients with obesity. The patients affected by obesity are at risk for development of fatty liver disease and hepatic decompensation. The patients who had A1AT genotyping performed from 2005 to 2010 were included in the study. The hepatic events were defined as either ascites or hepatic encephalopathy or esophageal varices or hepatocellular carcinoma. Binary logistic regression analysis was done to assess the association between A1AT-PIMZ and hepatic events. The patients were stratified by BMI class, BMI 25 to 29.9, 30 to 39.9, and BMI greater than 40. 2,237 patients with BMI greater than 25 were included in the study. 248 had PIMZ variant, and 1989 had the normal PIMM genotype. Total number of hepatic events recorded was about 20.7%. The PIMZ genotype increased the risk of hepatic events in all patients with BMI greater than 25 as compared to patients with PIMM with an odds ratio of 1.8, which was statistically significant. When odds ratio was adjusted for age, sex, and diabetes mellitus, the odds ratio remained significant. When stratified by BMI, the highest odds of developing hepatic events was for BMI greater than 40 and PIMZ genotype with an odds ratio of 2.32 with a p-value of 0.01. So the authors concluded that A1AT PIMZ genotype significantly increases the risk of developing hepatic events in patients affected by obesity. Alpha-1 antitrypsin genotype testing should thus be offered to patients with obesity or metabolic syndrome for risk stratification and counseling. Our last slide is on hepatocellular carcinoma. So as liver transplantation is the best treatment option for early stage hepatocellular carcinoma and cirrhosis. However, patients with various tumor burdens, even if they are all within the Milan criteria, receive identical listing priority. The primary aim of the authors in the study was to assess the effect of tumor burden score on wait list and post-transplant outcomes and transplantation-associated survival benefit. The authors obtained data from the SRTR database, which is a scientific registry of transplant recipients, and identified patients with HCC who were listed for liver transplant from 2002 to 2019. A competing risk analysis was used to calculate waitlist dropout, and Cox proportional hazards regression with a time-dependent variable was used to calculate transplant-associated survival benefit. A total of 36,634 patients were included in the primary analysis. About 24,457 were transplanted. In competing risk analysis, patients with higher tumor burden score had a 52% greater relative risk for waitlist dropout than those with a lower tumor burden score. If transplanted, these patients with a higher tumor burden score only have a 16% greater relative risk for death as compared to those with a lower tumor burden score. So liver transplant yielded a greater risk reduction in overall death among patients with a higher tumor burden score as compared to those with a lower tumor burden score. Essentially, what the authors have shown here is that even among patients within Milan criteria, a patient who has a single liver cancer of 2 centimeters and a patient who's got 3 liver lesions, with the largest being 3 centimeters, both get the same priority. Both of these patients get the same MELD exception points, and both these patients have the same wait time for transplant, even though the patient with the higher tumor burden has a higher likelihood of dropout from the wait list. So the authors concluded that patients with higher tumor burden score have a greater risk for waitlist dropout and death. Hence, liver transplant associated survival benefit is superior to patients with a lower tumor burden score. Hence, revising the current organ allocation policies for HCC is warranted. Thank you.
Thank you, Dr. Murali, for a wonderful review on the liver section. Just a couple of thoughts that I had is, especially as it relates to bariatric surgery, the first study that several studies that Arvind presented looked at restrictive surgeries versus a more definitive like a Roux-en-Y. And there's biochemical changes in just about any bariatric surgery that a patient gets, but sort of the long-term benefits seem to be a little bit greater with the Roux-en-Y versus the restrictive surgeries. And as there's more endoscopic procedures for bariatrics, I think we're getting data now similar to surgical data that shows that endoscopic plication offers the same type of benefit and improvement. So I think that's important because, you know, I think Shyam and the group are first to say, yes, you can do endoscopic procedures to drain pseudocysts, but is it better? The prospective randomized studies, and I think that's where the next phase for endoscopic bariatrics as it relates to NASH. The other study that Dr. Murali highlighted was UDCA for preventing gallstones. I think this is not a new concept. I recall from Journal Club back in 1995 or so, where we reviewed in Annals of Internal Medicine with rapid weight loss. That wasn't bariatric surgery in nature, that if you gave UDCA that you prevented gallstone formation. So this is now rapid weight loss from bariatric surgery that you prevent gallstone formation. So I think that's neat. A couple of the other slides I think that you took out, Irvin, that were pretty neat were the use of a PPAR delta agonist, and then the oxalic acid for preventing disease-free survival in patients with liver transplant that I thought were pretty neat. So I think that's pretty much my review of the liver, just because I'm not smart enough to know all the other stuff. But so I'm going to turn it over to Dr. Sunena Nathu, who's the Director of Quality Outcomes, to review the general GI portion.
So I'll be going through the general GI section of the DDW abstracts, and we're starting with esophagus. So this first study was by Delon et al. The clinical and histological improvements with weekly dupilumab treatment in adult and adolescent patients with EOE at week 24. This is a summary of part B of the 3-part Liberty Treat study. I love all the acronyms we come up with in GI. They're all very, very good. So the background of the study, dupilumab is something that we've been waiting for. It's a fully human monoclonal antibody that blocks shared receptor component of interleukin 4 and 13. Both are key drivers of type 2 inflammation that are known to be pathogenic in eosinophilic esophagitis. The goal of part B of the study was to assess efficacy and safety of dupilumab 300 milligrams weekly or every 2 weeks versus placebo up to 24 weeks in a larger sample size of adolescents and adults with EOE. A total of 240 patients were randomized in a 1-to-1-to-1 fashion to dupilumab weekly, every 2 weeks, or placebo. The primary endpoints that were identified at week 24 were the proportion of patients with histological remission, and this was defined as histological remission as evidenced by a decrease in eosinophilic count less than or equal to 6 per high power field, and an improvement in dysphagia score. And the dysphagia symptom questionnaire was used. This was an absolute change in addition to a percent change from baseline. And to give you an idea, this score does range from 0 to 84. The patients that were included in this study were symptomatic, severely inflamed with a mean eosinophilic count of 87 per high power field, and previously difficult to treat with 73% of patients on steroids and 35 requiring dilations. Dupilumab versus placebo was able to achieve histologic remission when compared. This was 58% versus 6%, and this was statistically significant. While there were no differences between placebo and every 2-week dupilumab in terms of dysphagia symptom questionnaire, there was a significant decrease in the absolute difference and percent difference when compared to dupilumab weekly and placebo. This was also statistically significant for both change that was absolute change and percent change. Dupilumab was well tolerated, with the most common side effect being injection site reaction, 87% that was in the dupilumab arm, and interestingly, 70% in the placebo arm. This study shows us that dupilumab 300 milligrams every weekly did improve clinical, histological, and symptomatic improvement in aspects of EOE and was well tolerated with minimal side effects. While dupilumab 300 milligrams every 2 weeks did not meet the outcome of change in dysphagia questionnaire score or the secondary endpoint of percent change, all other treatment outcomes, including histological remission, were achieved. Our next study is by Goldstein et al. Octreotide significantly reduces transfusion requirements compared to standard of care in patients with angiodysplasia-related anemia. As we all know, GI angiodysplasias are vascular anomalies that can result in transfusion-dependent anemia and multiple endoscopic interventions. Recent meta-analyses have shown, and in clinical practice, octreotide is used regularly to decrease rebleeding rates, although robust data has been lacking in this regard. The goal of this study was to investigate the efficacy of octreotide when compared to standard of care in reducing the amount of transfusion requirements in patients with GAID-related anemia. This was a multi-center nationwide randomized controlled trial that included 17 Dutch hospitals. The inclusion criteria were patients that required at least 4 units of packed red blood cells and or IV iron transfusions in the preceding year. Randomization was in a 1-to-1 fashion with octreotide LAR every 28 days versus standard of care for 1 year. The primary endpoints were the mean differences in the number of transfusions between groups, which was compared to the year before and after randomization. Endoscopic procedures were allowed as a rescue therapy, and the mean difference between groups was included as a secondary outcome. A total of 62 patients were included and randomized to octreotide or standard of care, and this was a 50-50 split. Of note, the baseline characteristics, including anticoagulation use and liver disease, were equal among patients. The total number of transfusions was lower in the octreotide group when compared to standard of care. And interestingly enough, octreotide reduced the number of transfusions significantly by 10, which was statistically significant. The endoscopic procedures were lower in the octreotide group, which was a secondary endpoint, but it only reduced the number of procedures necessary by about 1, which is also clinically statistically significant. Mortality rates did not differ among the groups. This study, I think, is important as it does show that octreotide can be an effective treatment for reducing the transfusion requirements and endoscopic needs of patients with GI angiodysplasia-related anemia. The tiny polyp trial. So this was a randomized controlled trial that was investigating the cold snare and forceps polypectomy among small polyps in rates of complete resection. So as we know, colonoscopy with polypectomy has been shown to be beneficial in reduction of risk of death from colorectal cancer. And we do know that complete resection is an important endpoint, as we know that there's a role of residual neoplastic tissue in the development of interval cancers. Both US and European guidelines have recommended that smaller polyps that were defined as less than 5 millimeters in size or small 6 to 9 millimeters in size should be removed by cold snare technique for higher rates of resection and lower amounts of residual tissue. The goal of this study was to determine whether cold snare retains a significant advantage over cold forceps for polyps that were defined as diminutive or less than or equal to 3 millimeters in size. This was a single study prospective randomized controlled trial evaluating cold forceps versus snare for that size I previously mentioned. There was block randomization, and patients were block randomized for removal by cold snare versus forceps, and biopsies were then obtained from the margin of the polypectomy site. The primary endpoint was non-inferiority, which was defined by the absence of residual tissue or residual polyp at the biopsy margin. A total of 180 patients were included, with a total of 280 polyps that were identified. This was pretty much split between cold snare and cold forceps. What they found was that the mean polypectomy time, as we can imagine, was longer for cold snare compared to cold forceps by about 20 seconds, which was statistically significant. However, there was a larger amount of patients that polyps were removed in more than one piece with forceps when compared to snare, and that was 15% versus 3%, and that was statistically significant. There were only 2 cases out of the entire 280 polyps that were removed in the study that had a positive margin biopsy. This suggests that there was a complete resection rate of about 99% in both groups. There was no statistical or significant difference, in cohorts and complete resection rates, demonstrating non-inferiority of cold forceps compared to cold snare. I think this is a very interesting study that we can use in clinical practice, as it shows that cold forceps are non-inferior to cold snares with the resection of small non-pedunculated polyps less than 3 millimeters in size. And it can be an effective alternative, especially because it requires less time to perform when compared to cold snare. This study is race and etiology are associated with risk for multi-system pre-existing lung disease and organ failure and pancreatitis, acute pancreatitis. This was an international multi-center observational study. Multi-system organ failure is a known devastating complication of acute pancreatitis, although independent risk factors or comorbidities in each patient are unclear how they affect overall outcomes and development of multi-system organ failure. In this study, 1,500 patients were included, and most were middle-aged, male, and Caucasian. 11% had clinically severe acute pancreatitis, and the primary outcome of multi-system organ failure was present in about 6% of the cohort. A multivariate logistic regression was used, and this was to evaluate what predictors in patient-specific qualities would show the strongest association with multi-system organ failure. They did show that existing COPD and alcohol etiology showed the strongest correlation with multi-system organ failure, followed by male sex and obesity. Caucasian race was also associated with a significantly higher risk when compared to non-Caucasians. This was the first large prospective international cohort of acute pancreatitis that found for the first time that Caucasian race, COPD, and alcoholic etiology were independently associated with multi-system organ failure. While male sex and obesity have been previously shown to be associated with organ failure, this study did re-demonstrate that, and these are important factors that we should consider when taking care of patients. These are some odds ratios associated with some of the factors that they found affecting multi-system organ failure, with the highest being alcoholism and etiology with 3.66 as the odds ratio, and with COPD 3.34. So here's a colon study. Efficacy and safety of the Vibrant capsule for chronic idiopathic constipation by Rao et al. About 45% of constipated patients remain dissatisfied with current medical management, suggesting the need for new treatment options and therapies. This is an orally ingested programmable vibrating capsule, or a Vibrant capsule, that has been found to augment circadian rhythm and increase stool frequency. The aim of this study was to determine the efficacy and safety of the vibrating capsule in patients with chronic idiopathic constipation. This was a prospective, double-blind, multi-center study where chronic idiopathic constipation patients were randomized to receive the vibrating capsule or placebo daily up to 5 times per day, 5 times per week for 8 weeks. The vibrating capsule was programmed to deliver 2 vibration sessions in the colon over several days, so it was over several hours per day. There were daily electronic stool diaries to assess stool frequency and other symptoms of constipation. The primary outcomes were the proportion of patients that had an increase of 1 or more complete spontaneous bowel movements per week, or 2 or more spontaneous bowel movements per week, at least 6 out of the 8 treatment weeks compared to baseline. Secondary outcomes were other symptoms such as straining, global improvement in symptoms. 360 patients were included and enrolled with similar baseline demographics. Of note, 85% of the patients were female. There was a greater proportion of patients that achieved complete spontaneous bowel movements once per week and twice per week with vibrating capsule compared to placebo, and both were statistically significant. Significant increases in the rate of spontaneous complete bowel movements were seen within 3 weeks, peaked at 6 weeks, and were also durable during the 8-week trial. The vibrating capsule also significantly improved other outcomes, including symptoms such as straining, stool consistency, and quality of life when compared to placebo. There were no serious adverse events of the vibrating capsule. Of note, there were more gastrointestinal adverse events that were noted in the placebo group, 9% versus vibrating capsule of 6%. 2 subjects in the vibrating capsule group did report diarrhea as side effects. This is an interesting, novel, non-pharmacological intraluminal therapy that was efficacious, safe, and well-tolerated in chronic idiopathic constipation patients. These benefits were seen soon after initiation and sustained, and represents an interesting way of treating CIC. Stomach study, predictors for favorable outcome after pyloroplasty for gastroparesis, and should response to pyloric dilation or Botox injection be used as a marker of surgical outcome? As we know, pyloroplasty and GPOM are effective therapies for medically refractory gastroparesis. The aim of the study was to evaluate pyloroplasty and GPOM in patients with gastroparesis and to determine factors in these patients associated with favorable surgical outcome. The secondary outcome of this study was to assess the utility of clinical response to preoperative dilation or dilation with Botox injection on surgical outcome, as this is a factor that's conventionally used to evaluate patients and to select patients for surgical therapy, despite lack of evidence to this effect. About 200 patients underwent either pyloroplasty or GPOM over an 8-year period. As you can see, only 30 patients underwent GPOM. Demographic and clinical data were analyzed for impact on surgical outcome. To assess whether pyloric dilation or Botox injections impacted surgical outcome, a subgroup of patients who had these preoperative interventions were assessed separately, and the favorable outcome was mainly clinical and was patient-reported improvement and resolution of primary gastroparesis symptoms, although there was a subset where gastroparesis or gastric emptying study was included. A favorable outcome, which was again an improvement in patient-reported symptoms, was achieved in about 78% of all patients. In that subset I previously described, it was 60 patients which had pre and post-surgery gastric emptying tests, with the mean percentage improved from 33 to 15%, and normalization of gastric emptying was actually found in 77% of all patients. Favorable outcome was not statistically impacted by etiology of gastroparesis, concomitant acid reflux, or primary symptom. Age greater than or equal to 40 was the only significant predictor of favorable surgical outcome on both univariate and multivariate analysis with an odds ratio of about 2.5. In a subgroup of patients, which was 128 patients that had preoperative dilation or Botox, the response to these interventions had actually no predictor on favorable surgical outcome. It was very interesting, though, that Botox injection prior to surgery, regardless of that patient's response to Botox, had a higher likelihood of favorable surgical outcome. In summary, symptomatic improvement after pyloroplasty or GPOM is independent of etiology of gastroparesis, presence of acid reflux, or primary symptom. Although response to dilation or Botox are not markers of response to surgery, patients who received Botox were 3.2 times more likely to improve after surgical intervention. Last but not least, we have an obesity medicine abstract. Endoscopic sleeve gastroplasty significantly reduces the comorbidities of the metabolic syndrome at a 5-year follow-up. As we know, endoscopic sleeve gastroplasty is a minimally invasive endoscopic bariatric therapy that is used to reduce the volume of the stomach to facilitate weight loss. While previously published data show 5-year data has shown significant weight loss effects that are durable at 5 years, there are a few studies that look at metabolic effects. The aim of this study was to look at how ESGE affects other obesity-related comorbidities at 5 years after intervention. This was a retrospective analysis of a prospectively held database of 255 patients. The mean BMI of these patients was 38. These procedures were performed with the Apollo endoscopic suturing system, and patients were included either if they were non-surgical candidates or patients preferred a minimally invasive endoscopic technique. Patients were then evaluated at 12, 36, and 60 months. The primary outcomes were the effects of ESGE on metabolic factors, including blood pressure, lipid panel, hemoglobin A1C, and liver tests. Follow-up data was available for 90% of patients at 12 weeks and then petered down as the study went on, but the mean follow-up in all patients was about 35 months. Patients showed a significant decrease in hemoglobin A1C, which was most pronounced in patients with diabetes. In those with stage 1 hypertension, they experienced a 9% decrease in systolic blood pressure at 12 months that was sustained at 3 years. There was nearly a 20% reduction in serum triglycerides that was apparent at 1 year post-procedure. Patients that had an elevated LDL had a statistically significant difference at 5 years. Interestingly, total cholesterol and HDL did not statistically change after 5 years. Additionally, there were significant changes by about 30% in ALT and 33% in triglycerides that were apparent and sustained at 5 years. This study does show that endoscopic gastroplasty is a minimally invasive endoscopic bariatric intervention that can achieve durable reductions. And this is both for total body weight loss, but also for obesity-related comorbidities and changes in the metabolic syndrome with changes in hemoglobin A1C, systolic blood pressure, LDL, and liver enzymes that persist 5 years post-procedure. Thank you, everybody.
Thanks, Dr. Nathi. That great review. I'm kind of back in my comfort zone a little bit here with general GI. Just a couple of take-home points that I got from going through the slides in your review. I think the first is we know that eosinophilic esophagitis is immunologically based. So it's right time that a biologic agent, this dupilumab, that Avendel, and it's a multi-center study. So I think, all of us are, we see EOE. There's not much we have to offer besides for either steroid slurries or PPI. So I think the next several years, we're going to see a lot more treatment options for EOE, which will be really exciting. The other study that you highlighted, I think, is really neat with the octreotide. There's many studies that we know of that since octreotide decreases splanchnic blood flow, even in non-variceal bleeding, octreotide does offer some benefit. So the fact that for AVMs, and this is really frustrating because, you can't treat the small bowel AVMs, at least unless you're doing double balloon, but even double balloon enteroscopy can be very challenging to get all these small AVMs. And the data that you showed was quite pronounced. I mean, you're talking about 20 transfusions down to 10 transfusions in octreotide versus non. So I think it's, and this is a single injection of octreotide. So I think that's a promising or another option to consider. The third sort of big take home that I saw was just, cold snare polypectomy versus forceps. I think even though there is statistical difference, 42 seconds versus 20 seconds, but what is the clinical difference or significance? I think 20 seconds in my mind doesn't really matter that much. And the other thing is that we're not very good at estimating size, so that if you have a small polyp and you think you can get it all out with a cold biopsy forceps, great. If not, I think there's other data that shows that a snare polypectomy, cold snare, gives you a little bit larger margin. In this study, there are equal eradication from both methods. So I think it remains to be seen, but for really small polyps, I don't think it matters how you take that polyp out. And finally, just leave it to Satish Rao to come up with some really neat novel methods. So this capsule that you can program and with it sounds like just control and cause vibration in the colon, and that led to increased bowel movements daily as well as per week. So I thought those are all pretty neat studies in my mind. There's a question. So the question from the audience is, was there anything that was mentioned in terms of losing the specimen? And the answer is that the study, at least in abstract form, did not mention whether the tissue was lost by which method. So, but those are all the sort of my thoughts. I think I'm going to turn it over to Dr. Uday Navneethan, who's the medical director for IBD, to summarize the findings from DDW.
So the first trial is the INTERPRET trial. So all of you use vedolizumab in clinical practice. So this randomized trial of vedolizumab dosing in patients with ulcerative colitis, the INTERPRET trial, we had more than 20 patients from our center in this part of the study as well. So non-response vedolizumab is common in patients with ulcerative colitis. Not everybody responds to vedolizumab. So optimizing dosage to increase the levels of the drug has been tried in patients. So this trial was an open label, phase 4 randomized control trial of vedolizumab in patients who received a standard dosing, week 0, week 2, 300 milligrams. And then at week 5, they had the measurement of the drug clearance, how fast they metabolize. So some patients metabolize the drug faster, some do it slower. So patients who metabolize it faster based on the level of the drug clearance, they were randomized into 2 different arms. So in the dose optimized arm, patients who actually had a level of more than 30 and less than 50 were actually given a higher dose of vedolizumab, 600 milligrams at week 6, and then 300 milligrams every 4 weeks. While patients with a really, really low dose of vedolizumab, less than 30, were actually given a really high dose. So normal dose of 300 milligrams every 8 weeks. So these patients are actually getting 600 milligrams at week 6, and then 600 milligrams every 4 weeks after that. So the primary endpoint was looking at endoscopic mucosal healing at week 30 to see how they are doing at week 30 in terms of achieving the Mayo endoscopic subscore of less than 1. So total of 278 patients were enrolled, of which almost 50% or more than 50% of patients not have a response by week 6, which is common. We don't see all patients respond by week 6 with vedolizumab because it's a slow responding drug. In patients, of these patients, half the patients received 108 patients received the standard dose of vedolizumab, which is 300 milligrams every 8 weeks, while the dose optimized arm received 2 different dosing, which I mentioned, 28, 27, and 2 different arms. And then if you look at these patients who did not respond actually had a higher level of fecal calprotectin and a CRP level. So patients who have a higher burden of inflammation, the higher CRP and a higher fecal calprotectin did not respond to the standard dose at week 0, week 2. So if you look at that, if you look at these patients long at week 30, the number was not significantly different. So at week 30, 18% or 9% patients achieved a standard dose vedolizumab response compared to 14.5% with dose optimized, which includes 2 different dosing. So at the end of this dose optimization is a negative trial technically. So at week 6, 47% of patients respond to vedolizumab. In patients who did not respond to vedolizumab at week 6 were dose optimized to the higher dose of vedolizumab. The response was not significantly different. So the take-home message for me is, if the patients are going to respond, they're going to respond slowly. So I think a lot of patients, you need to do a standard dose optimization of 0, 2, and 6, and then continue to follow up to week 30, and then make a decision at week 30 to see if you need dose optimized patients after that. So it's a cool trial because I think a lot of times we think that dose optimization makes a difference in outcomes, which is usually true with anti-TNFs, but not with anti-integrin treatment. So the next question is actually a very, very common clinical problem. Withdrawal of infliximab or anti-metabolite therapy in Crohn's patients in sustained remission. So this is a patient's question all the time. We would use combination therapy in patients with Crohn's disease. Can you withdraw one of the treatments after a particular period of time? So that's a common question. So this trial is aiming to address it. This called SPARE trial. It's a very interesting algorithm. So the aim of the study was to look at relapse rates and time spent in remission over 2 years after withdrawal of infliximab or anti-metabolite compared to the continuation of combination therapy in patients. So in these patients with Crohn's disease who are actually on combination with infliximab and anti-metabolite for more than 8 months on treatment, and actually when sustained steroid-free remission in 6 months, were recruited in Europe, or 64 centers in Europe. Patients are randomized to 3 different arms. The one arm was continue both treatments, continue infliximab and the anti-metabolite continually. The other arm was stopping the infliximab, which is more cost-effective in clinical practice. Or the other arm is saying, okay, let's stop anti-metabolite rather than infliximab. So, and then if the patient relapses, they're retreated with the same medication again, for example, infliximab, and they can optimize the dosing up to 10 milligram per kilogram optimization. So the endpoint where they looked at was relapse rate and the mean survival time spent over 2-year time period. So if we look at the trial, 211 patients randomized in 3 different arms, 67 to arm A, which is combination, 71 to arm B, and 67 to arm C. If we look at the relapse rates over 2 years, it's 14% in arm A, which is actually the combination treatment, 40% arm B, which is actually the withdrawal of infliximab. So they withdraw infliximab, they relapse much more commonly. The other one was withdrawing the anti-metabolite, which is arm C, where the relapse rate was lower again. The time spent in remission was 1.91 years, 1.89 and 1.93 in all 3 arms. So there's no difference in terms of time spent in remission. Again, if they relapse, they were again achieved remission in most patients after retreatment, which is a good thing. If you look at treatment failure, it's not much different in all the 3 groups, 4 out of 67, 4 out of 71, and 3 out of 67 patients in 3 arms respectively. So if you look at the result of the trial, it's very significant because if you withdraw infliximab in patients that are doing really well, they're going to flare. 40% of patients are going to flare in clinical practice. So, but the good news is all of these patients responded back when they were put back on the treatment. This is because these patients are actually on anti-metabolite, which decreases the risk of antibody formation. So that's a very, very important take-home message. So you're looking at cost effectiveness of therapies. There's one option to think about. But again, even if you relapse, you can always retreat them back with the medication and achieve the response. So the other thing is this trial is on tofacitinib for the treatment of ulcerative colitis about the safety data. All of us use tofa in clinical practice for ulcerative colitis. Always the safety comes in the picture. There's a black box warning saying that the high risk of DVTs and PEs is always a concern in clinical practice. So what is the safety we have over all the clinical trials? This is looking at phase 2, phase 3 clinical trials, all open label data of all the different trials for tofa in patients with ulcerative colitis. Included almost more than 1,200 patients with tofa in different doses, 5 and 10 milligrams twice a day. From all the studies so far, up to February 2020 completed. And we looked at the overall risk of infections, opportunistic infections, malignancy, importantly, major cardiovascular events, MACE, and then GI perforation. So all of these are more clinical endpoints to look at. So they looked at all those endpoints. And if you look at all the global Octave and the riveting clinical trial data, as you see, the dosing, almost 1,200 patients received the different dose of the drug, of which some received 5 milligrams, some received 10 milligram dosing. But if you look at the overall adverse events, including deaths, serious infections, opportunistic infections, which is OIs, malignancies, non-melanoma skin cancer, MACE, cardiovascular events, was not significantly different overall. If you look at the odds ratio, it's actually crossing 1, so not significant. The only thing which is significant is herpes zoster. So herpes zoster is the only thing which is significant signal, which came in all the clinical trials. So in clinical practice, you always recommend a shingles vaccine for these patients anyway. So this actually reassures the data that it's safe to use these patients. If the patient needs this drug, it's a very safe drug. Yeah, more than 1,200 patients data. If you look at the exposure, almost 3,000 patient is exposure, long-term data follow-up available, showing that it's a pretty safe option for patient ulcerative colitis. Again, this study is based on risankizumab. It's not approved for Crohn's yet. It's going to be approved this month for Crohn's disease management. Fortunately, we have one more option coming in for Crohn's. It's an anti-interleukin 23 inhibitor. All of you know anti-interleukin 12, 23, which is ustekinumab. There's anti-interleukin 23, which is risankizumab. It's going to be approved this year. But this study is looking at when do you position these drugs in treatment? I think a lot of us delay treatment options for Crohn's because we want to start something mild and go across the spectrum. The problem is if you delay the duration, the response is always not good as you see in practice. So this is looking at the question whether actually a shorter disease duration, actually, if you start them early in the treatment protocol, they improve outcomes long-term. So this looked at the randomized control trials, Advance and Motivate, in patients with active Crohn's disease who got intravenous risankizumab induction therapy and followed up to week 12 and week 52. And looking at options, looking at Crohn's duration, less than 2 years, 2 to 5 years, 5 to 10 years, and more than 10 years. So duration, looking at the duration of the disease and how the patients respond to each treatment option. We look at that, the data is very clear. That if you look at all the 4 slides for clinical remission, endoscopic remission in different time period, all the response is usually best when the duration is less than 2 years compared to placebo. So if you use the treatment early on in the first 2 years of disease or 2 to 5 years of disease, the response is much better than 5 to 10 years or more than 10 years. So the take-home message is, if you want to use effective treatment, you need to treat them early on the disease process before there is fibrosis and scar tissue. Because once you get to fibrosis and scar tissue, you're going to need surgery, endoscopic treatment to manage the strictures. So you want to use them early. And I think there is evidence from the clinical trials saying that if you use early treatment, you can achieve actually better endoscopic response and better clinical response in patients up to week 52. Again, the other question which comes in for Crohn's disease management is post-operative management. All of you know that Crohn's recurs within a few hours after surgery. People have looked at actually after surgery, looking at changes in microbiota in the resection site. So people have always looked into when do you start treatment to prevent Crohn's from coming back after resection. So this is a study looking at use of anti-TNFs and other available treatments for the treatment of Crohn's to see positioning these treatments and how to prevent it. So it's a retrospective cohort study of 2 tertiary centers in the United States where they looked at treatments. Patients got no treatment after resection, patients got anti-TNF treatment, and patients who got anti-integrin, which is vedolizumab, and anti-interleukins, which is anti-ustekinumab treatment. And they looked at within 12 weeks treatment after they started treatment, and then they stratified them into within 4 weeks and within 12 weeks after resection. And they looked at the recurrence of the disease on long-term follow-up. So we looked at Rutgers score, which is a score which you usually use for the prevention. It's I2B, so basically more than 5 aphthous ulcers in the neo-TI after resection. So we look at that. And if you look at the data is very, very promising. If you look at data within the first 4 weeks, use anti-TNF treatment, decrease the risk of any post-operative recurrence compared to using vedolizumab or ustekinumab. So if you use treatment in the first 4 weeks, you're most likely to go in to make a huge difference. We look at treatment starting within 12 weeks, then the odds ratio crosses 1, which means that the efficacy drops down in terms of decreasing recurrence. So in my practice, at least all our practice, we use within 2 weeks. So we use it routinely as long as the patient does not have an active infection. So this actually reinforces the data what we use in clinical practice, that we use treatment early on, particularly anti-TNF treatment. It makes a huge difference in preventing the disease coming back and obviously preventing future surgeries. Again, if you need more prospective data, this is a retrospective study looking at the data. Again, if you have more prospective data, randomized controlled trials, we support this observation very strongly. So I think the last trial is an etrasimod. I think all of you have heard of the drug called ozanimod, which is approved for ulcerative colitis now, which is sphingosine 1-phosphate receptor modulator. Now it's another drug, etrasimod, which is actually in phase 2 and phase 3 trials for ulcerative colitis and Crohn's disease. This is looking at once daily option for treatment in patients with or moderate to severe ulcerative colitis. Again, there's a phase 2 YSS trial, including Elevate UC12 and UC52 data, looking at patients with ulcerative colitis. Again, this is patients with moderate to severe UC who actually had a Mayo score of 4 to 9. And then we're looking at response with etrasimod and stratify the response based on the previous exposure to biologics or JAK inhibitor, which is TOFA, and then looking at baseline corticosteroid use and baseline disease activity, and looking at how the disease overall outcomes were. The primary efficacy endpoint was clinical remission at week 12 and week 52 in both the trials. And if we look at Elevate UC12, just short-term study, it's only a week 12 follow-up. So looking at all the endpoints, 433 patients are randomized for the 52 trial compared to 354 patients. So both these trials, a large number of patients were randomized to etrasimod and placebo. And we looked at all the patients who completed the trial, and most patients actually were naive to biologic or JAK therapy. They are bio-naive or bio-JAK naive patients, almost 63% of patients. And almost all the endpoints, including endoscopic remission, clinical remission, are superior with etrasimod compared to placebo. So I think this study shows that etrasimod is going to be available for us most likely next year, another option for ulcerative colitis. And it includes actually provide a symptomatic improvement, including statistically significant improvement, endoscopic and clinical response in patients at week 52, giving us one more option for patients with moderate to severe UC. Again, I think this is for my slides, and I invite Dr. Mishra to comment on these slides if we can. Yeah.
Great. Thank you, Dr. Navneethan. Great review. It just reinforces that we need brilliant people like Uday doing this rather than folks like Shyam and me doing EUS to understand all this. So just a couple thoughts. It's, I think, a lot of exciting things. What I took away is just kind of grouping predicting failure. You know, how can you predict failure? Which patients are going to respond or not? I thought that was pretty neat. Also, there's some data, I think, in some of your studies where if you use triple therapy for high-risk Crohn's disease patients, that was pretty exciting. I thought the SPARE trial was really neat. So the question is, which agent can you remove? Can you remove a biologic such as infliximab versus an anti-metabolite? And patients where the infliximab or biologic was withdrawn, they had a much earlier recurrence and worse response afterwards. So that was pretty neat, because the goal is always, you want to, there's other studies that show that if you, especially in young males, that if you're on biologics as well as an anti-metabolite, perhaps those individuals have higher lymphoma risk. So the goal is always to try to remove certain things that may cause harm to the patient. So, which ones can you remove, which ones can you not? So I thought that was important. One of the other studies you had reviewed previously, biomarkers to predict failure. So these are blood-based tests to see which patients might fail. That I think that would be pretty neat. The early initiation of an anti-TNF to prevent post-op recurrence. That's always a question that you're going to get asked by surgical colleagues is once they do undergo surgery, what can you do to maximize the patient's response? So I thought that was neat. You also had previously some epidemiology data with IBD, which I thought was pretty neat, using large databases from Denmark, that there's increased UC and Crohn's disease in younger patients, but in the older patients, there's a higher risk of ulcerative colitis and not as much as Crohn's disease. So again, those are my thoughts on the IBD section. I just want to thank all of you. I know the audience here, you're pretty eclectic and a select group to be invited by the Orlando Health Digestive Health Institute. So I know they mean a lot to you, and all of you mean a lot to me for inviting me. So thank you. I know there's going to be great things. There is no doubt. You can see it. You can feel it. The Digestive Health Institute at Orlando Health is special. So thank you again for inviting me.
Thanks everyone for joining us. I think the presentations were fantastic. Great job, Uday, on the IBD. Even I could learn something about IBD, but thanks to Dr. Bang and Dr. Nathu, Dr. Murali, and Dr. Navneethan for this fantastic presentation. And most importantly, thanks for all of you watching worldwide. I know there are several from UK, and several from Abu Dhabi and a few from India have already texted me, and one from Japan. So no matter where you are, I think it's very late at night. Go to sleep, and hopefully we will do this again next year. But for all our friends here, such an awesome opportunity, not just to educate, but to see you all. Thanks for coming. Good night.